Good morning, everyone, and welcome to the start of Day 3 of ICIC 23 and our final day. Fantastic that you've been able to join us for our session on inclusive engagement. I'm Mandy Andrew, and this is my friend and co-chair.
Hi, Anne Wojtak from Toronto.
And obviously, probably from my accent, I'm from Scotland, from the Health and Social Care Alliance. We're going to run through our presentations. Sorry, I should say welcome to everybody who's joining us via live stream and online as well. We're going to run through the presentations concurrently, and then we'll take questions and answers at the end as well. So fingers crossed we run to time. Can I just point out to folk who are live streaming us, we have got an additional co-chair and friend with us. We've got a beautiful skeleton of a whale hanging from the ceiling. And Jacqueline the elephant, who's outside the door, who was the first elephant of Antwerp Zoo. So without further ado, I would like to ask Charles to come up to the stage to take us through his first presentation.
Hi, morning everybody. So I've been already presented. So my presentation is focusing on how engaging communities can be part of the integrated health care. So it's based on a study that we did during the COVID pandemic in 2020. So it's 2 years old, but still relevant. And I'm speaking on behalf of other researchers from the Institute of Tropical Medicine here in Antwerp, 10 minutes walk from here. So I just give you a bit of background of what I am going to present. I am working on a small project in the Institute of Tropical Medicine here in Antwerp, and our project does sexual health promotion among African communities here in the Flanders. Belgium is very complicated, so we have regions. I think you already heard that. So we are working on African communities, so-called sub-Saharan African communities living in the Flanders, so we don't go to Brussels and we don't go to Wallonia. So we are doing health promotion, sexual health promotion, and the prevention of HIV. Our project was inaugurated in the 90s during the HIV pandemic, and we are sponsored by the Flemish Agents for Health and Health Care, the Agentschap Zorg en Gezondheid. So how do we operate? We are a field project, but we also do intervention research. So how do we do that? We, in fact, reach out to the communities where they are. We don't sit behind our laptop to define, the needs and the goals of communities, but we go to communities, and together with the communities, we define their goals, and we also assess their needs. So as you can say, the year was just before the pandemic. In the year before, in 2019, was the Gay Pride, because we're working on sexual health promotion, the Gay Pride here in Antwerp. And the picture in the middle is our work in bars. We work a lot in bars and cafes, and in churches, in shops, so-called African shops, if that exists, and so other exotic shops. That's where we do our outreach. So we do outreach, we go out to communities, but then 2020, beginning of the year, the pandemic broke out and the lockdown was announced here in the whole country in Belgium, so we could not reach out. So, meanwhile, the province of Antwerp already in 2020 was figured as number one rating in the level of infections of COVID-19. This was via the media coverage, and it was also through the anecdotal clinical information. But we as people who work with communities, we knew that communities have a very, very strong social cohesion. They live very much together. They live in overcrowded houses, and that they are very, very mobile. So there's a lot of movement between the African communities here, between the cities. So people go to visit each other in the different cities and villages of Antwerp, but also across the borders in France, in Germany, in the Netherlands. And also we knew that the majority of people whom we work with have a language barrier. Here we speak Flemish, but most people don't speak Flemish. And most of the information about the pandemic was either through French or Flemish. So then we thought these factors could maybe also increase the risk of COVID transmission. Meanwhile, the governor of Antwerp by then also kind of felt there was need also to maybe to do some focus on the so-called vulnerable groups, because she was afraid that maybe these people would be much more vulnerable to COVID-19. And because she was the chair of the board of governors of our institute, so she asked us to do the study. So excuse me, how do you go back? So why did we do then this study? Because of course we couldn't reach out to the communities physically. So we wanted to explore the information and the prevention needs of the communities, racialized and ethnic minority communities. And we chose purposely 4 communities in Antwerp. So the Orthodox Jewish communities. All this was based on what was going on through the media. So we are relying on the media, you know. The media here in Belgium was already talking about the danger of COVID spread among the Orthodox Jewish communities, the Moroccan communities, the sub-Saharan African communities, and the Turkish communities. So we wanted to also to examine the coping mechanisms of these groups and how they coped with the control measures that had been imposed. And we also wanted to understand their different perceptions of the pandemic. The COVID pandemic, which is now history, was understood by different people in different ways. And this was very important. We also wanted to understand and analyze the impact of COVID and its control measures on the lives of people. And finally, we also wanted to dig into how these communities already got involved in the responding to the various challenges of the pandemic. So the methods we used are the typical social science, so the interpretative ethnographic methods. So we used the semi-structured interviews, group discussions, and at the very beginning of the study, we also set up an advisory group from the communities themselves. And as I said, the results I'm going to present were all from the semi-study of the sub-Saharan African communities with which I work. Other colleagues worked with the Orthodox Jewish communities, and other colleagues worked with the Moroccan and Turkish communities. And all the 3 sub-studies have been published in the International Journal of Equity in Health. So we chose the study participant, of course, using the convenience sampling. We already had people, so we work with a network of people in the communities. So from these, we chose then the key person, the so-called key informants and other people. So these are leaders of the communities and church leaders of mosques and churches, but also some other key persons. 27 participants, we recruited 27 participants, which was not at all easy because, you know, we work face to face, but then you had to depend on the telephone and a lot of WhatsApp. 7 participants were male and 10 were female, and the majority of them, of course, because we chose purposely, we knew that we need people who are at least with a high level of education. So this is how we collected data. We used the telephone and then lots of WhatsApp and then the Zoom link for people who could connect. But this had a lot of challenges because of the poor internet access and so on. So I'm going now to present the results, the findings from the study. So when we collected data, after collecting data and analyzing, we grouped the findings into 7 sub-themes, which were grounded in the data. So the theme number one was about the information. How did people get information about the pandemic? The second theme about the knowledge and adherence to the prevention measures of COVID-19. The third theme about attitudes towards the 3 main aspects of COVID-19, that is the testing, the people who were infected with the pandemic, and of course, by then already, the assumption that a vaccine would come. And then the collateral effect of the lockdown on the people, the community engagement, which was the most important, and then the intersecting vulnerabilities that we already knew, and then the participant recommendation came as an additional theme. So these are the details of the findings. Concerning information, we learned that people, not to our surprise, but already to what we know, in fact, their information about the pandemic was mostly through social media, not through the television. You can ask me why. I think it's a matter of fact based on what I said, because most of the televisions here, all the televisions are either in French, in German, or in Dutch. So then people who cannot speak this language resort to social media. So they were getting their information via social media. There was a lot of misinformation. Many people were vulnerable to this misinformation, and then also the control strategies of the pandemic, especially the lockdown, had more negative impact than the virus itself among the communities. And then the social and political vulnerabilities, such as being migrants, being undocumented, having experienced racism and discrimination, these combined with economic factors to increase the burden of the pandemic. And then the communities, despite these obstacles, the community, through their leaders, improvised in fact, ad hoc solutions to the pandemic-related challenges. For example, filling in knowledge gaps, that is giving information to their community through WhatsApp mostly, developing creative solutions, for example, to combat misinformation, translating prevention strategies that were given through the television, the mainstream television, helping with the administrative issues, and also providing social and spiritual support to their members. These were the recommendations that came out from the study participants. Recommendation number one, they said, of course, the television is very useful, but I think the information channels have to be diversified. And also they said that the people's capabilities and limitations should be taken seriously, and that community engagement, the initiatives in the communities would be better supported, and that misinformation should also be tackled, but we should understand first why are people prone to misinformation. No, we are running to say, okay, migrant communities are very vulnerable to misinformation, but why? So this is another area that people said we should maybe explore, and also then to recognize, of course, the initiatives that were taken by the communities themselves. And these were the lessons we learned from the study, that community engagement, which is an evidence, is very, very important. So each communities have to be involved because of the specificity of the communities. It's surprising that how the Jewish communities, the Orthodox Jewish communities responded was radically different from how the African communities responded and so on and so forth. So the communities in their particularities should be involved in the prevention strategies. And then that prevention among such groups should be approached in an intersectional way because the causes and the vulnerability intersect with each other. And last but not least, that we should build on the strength of the communities because I think we focus too much on the vulnerability. When we were doing this study, I think the word from us researchers, vulnerability came like 1,000 times. I said, I think communities, what I read from the research, there's lots of also capabilities and lots of strength on which we can build. So thank you very much. Then I'm looking forward to your questions, maybe which will be at the end. The questions will come at the end, I hope.
We'll take all the presentations one after the other, and then we'll take questions.
Great, great. Okay, thank you very much. Then I pass to the next speaker.
Thank you, Charles. And I'd like to welcome up Sandra from the UK, who's going to be introducing her team and the work that they've been doing to develop a continuum of integration to enhance well-being and reduce inequities.
Thank you, everybody, and good morning. So my name's Sandra Crosdale, and along with my colleagues Andrew Hulcoop and Dr. Salman Shahid, we want to talk to you today around how we've integrated our services in Rochdale to give ourselves the best opportunity to improve outcomes for our population. So a little bit about Rochdale. So, am I on the right? Oh, sorry. I'm a bit in front of the slides. There we go. So a little bit around Rochdale. So Rochdale is a town that was a real boom town of the Industrial Revolution. And it's a really diverse community. So you can see from the pictures there, we've got some absolutely fabulous green spaces, some beautiful landscapes, some amazing architecture, but actually some really deprived areas that cause us there's a real inequity across our system, across Rochdale. It's got a population of 2,400 people approximately that are really, really diverse. So the life expectancy in Rochdale is 2 years lower than the national average in England, but that's just a small part of the story. The real story in Rochdale is that if you're a man born in the most deprived area in Rochdale, you're likely to die more than 10 years earlier than somebody born in the most affluent area of Rochdale. And that for us isn't acceptable. And that's what drives us to really work in the integrated way that we do to try and reduce those inequalities across the system. So you can see there we've got some real poverty and deprivation in the borough. We have some health challenges. We are a hugely diverse population, and actually we have some low educational achievement and digital exclusion, and it's really important to us that we address all of those issues. And we know that just focusing on trying to improve our healthcare services will absolutely not deliver improved health outcomes for us in Rochdale. So what we've done is develop a vision for our whole place, and we've worked with our residents and our partner organisations to do that. And you can see that up there, I'm not going to read it out. But we know that to deliver that vision, it's absolutely fundamental that we work across all of those different areas that we've described as our building blocks in Rochdale. So if we don't work with the education system, if we don't work with housing, if we don't work with work and skills to get people in work, no matter how good our healthcare services are, we won't deliver the outcomes that we want to. Which is why we've fully integrated our system. So that might sound easy, it's not. So I want to talk to you a little bit about how we've done that. Practically, what does that mean for us on a day-to-day basis? So I appreciate it's a really busy slide, this, don't worry about it, I'll talk through it. So back in 2018, excuse me, we established something called a local care organisation. That's not a single organisation, that's a partnership of all of our health and care and wider determinants people coming together to work as though we were a single organisation. So I've got a list because I always forget to say somebody. So that involves our primary care services, our community healthcare services, our hospital healthcare services, public health, mental health, social care, working with our hospices, working with our carers organisations, and really, crucially, working with our voluntary sector. So what does that mean on a day-to-day basis? Well, we've got integration across all of those areas at every level within our working organisation. So at operational level, at senior management level, at executive and board level. So what does that mean? That means that we think together, we solve problems together, we understand our population together and our risks, and that means that we can absolutely put our residents at the heart of our decision making and not put our organisations at the heart of that decision making, which is absolutely fundamental. So a really quick example of what that's meant. So would you believe it if I said to you that this winter we put £500,000 of money that normally would have gone into a hospital system to support us getting through winter pressures. And we collectively decided that our single biggest risk was people living in cold homes, because actually we know that those people will have exacerbated health conditions, they'll end up in hospital, and actually when they're in hospital, it'll be so hard to get them out of hospital into an unsafe cold home. So we invested £500,000 of supposedly health money into a warm home schemes to really support our population. So that's just one example of the type of things that we do. And all that isn't easy. It's not easy to navigate. And Andrew has now got the job of explaining some of the complexities around some of that and talking you through how we navigate those complexities. Andrew.
Thank you, Sandra. So my name is Andrew Hulcoop. I work for the Northern Care Alliance, which is one of the partner organisations within the Rochdale system. My part of the presentation is trying to talk you through... Big green. Big green, not small green, sorry. Talk you through some of the structural barriers to integration that still exist. So Sandra's described some of the great joint working that happens in Rochdale, and I really love that phrase that we sort of think and solve problems together. But it's been great, I say great, it's been interesting throughout the conference to hear from some of the structural barriers to integration that we experience, and I think people in other countries and other care settings experience as well. So we still have a scenario in the UK where our primary care services, our acute and community services, our social care services, mental health services, services provided by the voluntary sector, they're all provided by different organisations, and whilst to some extent that's healthy because we've got a really great sort of mixed economy of providers within the locality, it does mean you're working within a system where you have the risk or potential for organisational silos, individual organisational cultures, ways of thinking, and organisational strategies that when we're trying to commit to a single system approach within Rochdale still needs navigating. And alongside that, those organisations are all responding to external pressures, regulatory pressures that are not well aligned. So we're still, by and large, as organisations, assessed on the quality of services that we provide, not necessarily our contribution to the population health outcomes or how well functioning our overall system is. And that can put pressures on organisations when they're trying to balance those priorities. And some of our partner organisations, including the one I work for, span footprints that go beyond Rochdale, so they have to balance priorities for the town as well as priorities for their wider organisational population. I've heard a lot in the conference about the challenges in using data effectively to support effective population health management, and we still experience some of those challenges. Moving data between organisations, collating data in a way that allows you to make sense of what's going on in the population and what interventions will have the biggest impact, and having a sort of true patient or person record that is really aligned to the difference that you're trying to make to them. That's still a challenge for us as well. And finally, the funding that comes into organisations is still often orientated or largely orientated around the provision of services as opposed to working together to deliver improvements and outcomes. And again, that can pose challenges in prioritising resources, and also it's still difficult to share or pool resources, although Sandra's given us a good example in a system of where we've managed to work around that. So I think for some time within Rochdale, we were thinking one of our ways of getting around that or moving forward past that would be to, as far as possible within our integrated care model, bring our services together into a single contractual framework, a single funding arrangement that would allow us to pool budgets and allocate resources where it best meets the needs of the population. And for a variety of reasons that I won't go into too much detail here because we don't have time, we've slightly moved away from that strategy somewhat, partly because of changes in government policy, which means it's changed the way money flows into organisations and the way some of our commissioning arrangements operate, but also because there's a risk with that approach that you become less inclusive in how you design and deliver care, because you can become fixated on what is in scope for your formally integrated care model and what sits outside of that. And there's a bit of a risk of us losing some of the whole system engagement that we've had in Rochdale to date. So what I wanted to briefly describe to you here is how we've used the concept of integration as a continuum to try and help modify some of our thinking so that we can still work together to deliver shared outcomes and still, in some cases, work in quite a close, structurally integrated way, but have a model which allows us to be as inclusive as possible and ensure that all the partners in our system are able to contribute to that. And one of the conversations we've had locally really is that we shouldn't confuse the degree of structural integration with the amount of impact that an organisation or people can have in the system. So I'm going to briefly describe this, not go into too much detail because of time, but as I said, we've tried to create a model which allows us to position organisations and services along an integration where it makes most sense for them, and also where it makes most sense for our model. If I start on the left-hand side of that model, we want as wide a possible net of organisations and services that feel that they're part of the model and are in scope, even if that means that we're collaborating in quite informal ways or sort of without some of the underpinnings of structural integration that we have elsewhere. In the centre of the model, the sort of one-team approach, with some of our services, we will look to, or have looked to, sort of co-locate them within the same physical building, and also have those teams working, regardless of what organisation that they work for or what professional group they are, as if they are one team, and explore where that makes sense to have the same sort of policies and procedures, sort of look at arrangements that can support that, like single line management across a range of professional groups. And some of the conversations, some of the examples that Sam will give about our neighbourhood model will help to sort of articulate that and bring that to life. And then still on the far right of the model, we will still look in some cases, or have looked in some cases, to bring together services in a more formal structural way. So for example, over the past 5 years within Rochdale, we've moved to a scenario where our hospital and community adult and health children's services now sit within one organisation. And there are still times when that makes sense to do so, where that brings synergy between those services and provides the right kind of governance support for them and their contribution they make to the system. So hopefully that's been helpful in understanding some of what we've tried to do as a as our integrated care model. And I can let Salman take the stage. He's going to give you a bit of an example of how that's made a difference on the ground with our communities.
Thank you much, Andrew. I think Andrew missed the 5-minute sign signal, so I've been left with 2 minutes only. So quickly jumping on to our neighborhood models, the important bit I would like to point out here that because I'm the Associate Medical Director and GP and family physician is being called in various countries, so I'm heavily involved in working at the PCN level, being a GP, where obviously is sitting at the heart of the neighborhood model. The important bit here, what I would like to point out, is the neighborhood leadership group, because that actually brings together the political leadership and clinical and professional leadership on one single platform, that how we can actually sit together and define our shared priorities. And that's actually based on the patient's view about their health and care needs, which is being represented by the political leadership, and clinical and professional leadership then brings that into equation and ensures that is being delivered as a part of the integrated care system. Yesterday we talked about social prescribing link worker in plenary session. We heavily work towards social prescribing link worker. As the name indicates, that they are link workers, they are community connectors, and they really help us in integrating our services, which obviously we're still learning. We started at 2018, we're still a long way to go, but there is some good work which is being done, because we try to equip the social prescribing link worker with the right information, particularly around the vulnerable adults, those who had intellectual disability, learning disabilities, and the elderly care population. So these kind of cases are being picked up in the community. Neighborhood team, anyone can obviously refer to the social prescribing link workers. They take that case load and then they go and see the patient and find out, what's the best service available in the neighborhood for the patient. Quickly going through the case study, I like to tell stories. This is one of the story of one of our patient, 79-year-old lady. She was not being seen for quite some time during the COVID pandemic, and then came across one of the clinical encounters over the phone with the GP. It was being found that she was not being seen for 3 years. So GP asked the social prescribing link worker to go out and see this patient. And it was being found that despite of having the private carers, it was not being very well looked after, living in anti-ID and unkempt condition with low mood and depression. So the immediate response was, activating our neighborhood team. We made the referral to the social care system, where they came and do the assessment in terms of safeguarding. We activated the mental health practitioner who did the mental health assessment. They are being kindly directly linked with the hospital system for mental health support. And then we had the community matron who did all the nursing care needs, analyzed that, referred for the wound management, and GP visited who did the initial assessment and made the referral for the falls clinic and the frailty clinic. So that briefly shows, obviously we are limited with the time, but that shows that how actually we are clinically integrated within the system as well, and we are actually trickling down not at the strategic level, but at the right at the bottom when patients need the care, we're trying to improve. And obviously, it's a long way to go. It's still learning out of this. We've got a strong reflective practice model, which we did in our presentation yesterday as well. And personally, I believe communication is the key. More you communicate within the team, more you'll come across. And that level of understanding in between the team, that is my patient or your patient or this system, that is actually within that walls, 4 walls. But when you come and speak about the patient should get the benefit of whatever we are discussing here. Leave the last minute for.
One last minute, yeah.
Thank you.
So I'm just going to sneak back literally for 1 minute, if you bear with me. So that's great, isn't it? Talking about an individual is brilliant, and we can see the impact on that individual who we definitely supported their health and well-being. But what does that mean for us in our system? So actually, it's really hard to measure things that don't happen, isn't it? But I'm going to hypothesize that actually, if we hadn't have supported that lady in the way that we supported her, it was very likely that she would have ended up in hospital, because she would have been malnutritious, she would potentially have been dehydrated, potentially lead to a fall, and ultimately end up in hospital, likely to further decondition in hospital, and ultimately end up coming out with some form of care package or into residential or nursing care. We can't measure that because it hasn't happened But what we can do is measure our system metrics, and they are starting to tell us now that our integrated journey is working. So if we look at our A&E attendances, if we look at our admissions, our non-elective admissions, they're going down now by about 4%. They are 4% below plan, and that's in the context of everywhere else demand going up in the system. So actually that's starting to tell us that we can see our integrations working. We really, really appreciate your time today. Thank you very much for listening, and we'd be delighted to answer questions.
Thank you so much. Fantastic two presentations there to kick us off. Without further ado, I'd like to invite Sharon and team up onto the stage who've come from Alberta to tell us more about support for collective well-being. Ladies, the stage is yours.
Good morning. So thanks for joining us this morning. We're here to talk about our work with rural communities in Alberta, a project called Connecting People and Community for Living Well. So just flip to the next slide here. I won't go over the overview too much. We'll spend time more on the discussion. You know, I can't even count the amount of times in the last couple of days that we've said how incredible it is to be in the company of people who are doing similar work, hearing about the research, the meaningful engagement with those with lived experience, and the practical application has been phenomenal. And to be in the presence of so many like-minded people is so invigorating. The work that we have been doing over the past number of years is focusing on well-being and how that is supported at the community level, both for individuals and for collectives. So over the course of our time working in this space, we've developed a model which is called the Connecting People and Community for Living Well model. And it's grounded in that support for well-being in the community. And I won't go into all 5 components. Helen and Karen will speak to them in a few minutes. What I want to draw attention to is the 10 core principles, which are at the top of the screen. And really the model is intended to be provide enough guidance at that local level for community teams as well as for the provincial work, but it's flexible enough that it can be adapted to that local context and within the particular situation. So the evaluation component that's been done for this work, and I think we've also heard over the last few days how challenging it can be to evaluate this type of integrated work. The work that we've done has been evaluated through a principle-focused evaluation, and so these are the 10 principles that our evaluation team has started to understand at that local level. How are they applicable? And then how is our team implementing those principles? So what is this collective well-being? We learned in demonstration work that happened in 2017 to 2019. The work was really looking to support or increase capacity at that local level for supporting those affected by dementia. And that included both those with a diagnosis as well as their carers. The work at that time was really, from an evaluation perspective, looking at those system levels. And so our colleagues just prior spoke a little bit about the invisible, and that is one of the things that we talk about in our work, is how to make that invisible visible. I think some of the myths, which many of you might be familiar with in this work, is that it just happens naturally, but anyone that works in the space also knows that it's not a natural progression. We're such a siloed kind of approach to caring for individuals, it creates the space for that need for integration. And so what we learned in that time that the communities that were participating, really, we were seeing an impact in those healthcare system measures, which were a reduction in unplanned emergency department use and length of stay. In addition, it was proving to show really great return on investment, especially in rural communities. But we knew there was more to the story. The community teams we were working with were saying, you know, our community members are telling us they know better where to go and who to connect with to find services. And so we knew there was something kind of magical happening there, which led us down the path of collective well-being. What was happening in those community groups that was really creating that environment to have no door be the wrong door, and for people who were seeking services to be able to know where to go for that. So I'll hand it over to Helen.
It's actually right here.
Okay.
Perfect. I just want to step back a little bit in terms of these community teams we're talking about. They're multi-sectoral teams. So some of them include healthcare, but actually some of our communities actually have very little involvement of the healthcare silo. Others, most of them have the social sector involved, volunteer sector, some have the municipal governments involved. It's a really large number of players, and each community actually is quite different that we work with in terms of who they've kind of been able to pull together. And it's quite amazing, in fact, like who they've pulled together to do these things. And I think that multi-sectoral approach is really integrating the care within these communities and making it easier for them to actually help people navigate. And in our project context, people living with dementia and their caregivers. I'm just going to get the button here. So we talked a little bit about how the initial research was actually looking at those metrics that the system cares about, hospital admissions, ER visits. But what the communities were telling us is that it actually that stuff didn't really matter to them as much. They wanted to measure how do they measure their progress, how do they go forward with what they're doing and the things that they're seeing that are helping people individually. And the last presentation where it's just those individual stories, we have so many of those coming from the communities, and it's so heartening. So when we kind of approach this next phase of our project, we wanted to do more research around what helps around the collective well-being of these community collaboratives and multi-sectoral teams. And so we looked into the literature and really didn't see that much around it. So we actually ended up doing some qualitative research around it with the communities that we have involved. So we conducted a lot of focus groups and really kind of got that saturation and pulled out what really made things work for teams and perhaps things that were not working. So this slide is more about our learnings from the research about what really contributes to the collective well-being. Some of them are not at all surprising. And the first one is that time and resources. Everybody talked about how they were doing this off the side of their desk. It was not actually their job, to work with these collaboratives and to make things work together, but they all saw the value in it in terms of working together. And they just talked about how, they need to have that acknowledgement of their bosses or whoever they're working for to help give them that time and resource to do this very, very important work. And, they talked about joint purpose and that almost like that altruism of wanting to help other people is so important. And, I think that was really reflected in it. And they really wanted to have outcomes focused, right? They wanted to see that their work was making a difference, which they did, but they also wanted to be able to measure it, which we'll talk about later about the other things that we created. And I think I've heard this many times at this conference already, relationships are key. You don't get anywhere without relationships. And, finding those people locally to help connect to the most vulnerable and help the people in need is so, so important to them. Policy is something that they also brought up in terms of, it's more of a challenge in terms of political policy and priorities change constantly, which I'm sure is the case everywhere. And it's very frustrating with them. And the communication piece is more, not just communication within the collaborative, but actually how they communicate to their community. Many communities have found very interesting ways in order to engage people in different ways, and not just, putting a bulletin up at the doctor's office, to try to recruit people to do something. It's lots of really interesting ways. And the diversity in membership has been so important to them. One of our communities, they keep saying, the weirder the mix, the better the fix. And we're like, that's fantastic, you know? And it's true, right? They have such innovative ways to solve problems and make things so much better. And I think that they want to continue to learn and continue to progress forward. And that last item is something that's, of course, I think very apparent to people, is that you really need the people with lived experience to be involved in the process and to be there for the community, as well as to make sure to check in with the people with lived experience that what they're doing actually is making a difference to them individually. So I wanted to point this out. Provincial support was one of the 10 items that was in one of the initial slides that the communities have actually pointed out as something that's very key to allow them to do the work that they're doing. They felt, particularly in the pandemic, but even before that, they were kind of, you know, unmoored. They didn't really have that support that they needed. And so what our team provided to them was actually an ability to reach beyond their community, as well as connecting the communities to each other, which they didn't have before because they're kind of all separate, and allowed them a platform to share ideas with each other. And as well as like having that experience at kind of an outside level to provide moral support, but also mentorship in terms of whatever they wanted to accomplish. And we were kind of quite objective people. We're not there top down telling them what they need to do, which is unfortunately what the communities are used to, and I'm sure you guys are used to working with communities that are under that kind of thing as well. But we're just there to support whatever they want to do, what kind of initiatives, what kind of changes they want to make. As well, it helps them, you know, really build those local teams and kind of give them a bit of guidance when they need it. So two of the outputs of our research and our work are the well-being guide as well as the competency framework. We have a little card that I brought up here that's on your table. It has a QR code. These resources are linked to our website. They're under the resource bundle. So if you guys want to look at those more carefully, because we don't unfortunately have too much time to talk about them. But the well-being guide is something that we created out of the research that we did, the findings, as well as many iterations were done with the communities to actually make it something that they can use to look, take a shot of what's going on, like paint a picture of what's happening in this community, what are the strengths here, what are the gaps that are happening, what do they really want to work on, and it also has like a rating system, a red, like a traffic light, you know, red, green, and yellow, about where they are in terms of where they want to be, so that you can measure actually the progress in terms of the areas that they wish to measure. So this is something that the communities have been finding helpful, and also helps them show the work that they're doing. It's like, you know, we were in the red and not doing well on this area, but now we're doing green and we're doing lots of progress. So they're like enjoying that. And the competency framework is something that, we're using that is the skills and that are needed to create a functional collaborative or coalition within these communities. And so it's kind of a bit of research as well to help any new communities that are coming on to kind of let them know what maybe are the baseline things that need to be there to help that going on. So take a look at those, and I'm going to pass along to my colleague Helen now.
Thank you. So yes, we've had lots of learnings that have come from the work with the communities, as well as what we've learned through the Wellbeing Guide and our evaluation activities. So just to share some of that with you. We thought we'd start with the actual communities and what does integration look like there? What has it produced? You see some of the highlights there, and I'll go through that, but also just to let you know, these 5 rural communities actually have created 60 different activities across them, and they had very little seed funding. They had about $6,000 for each of those. They've also been able to gather other grants by being part of this work, and so have brought money with it into their communities too to do this work. And these are really communities that didn't have supports for people living with dementia and carers before, so it was a net new for them to come together to do this. So within Westlock, they were able to form their Building Compassionate Communities. They really work with people with lived experience. They're part of their team, and they help direct what programs get developed. They've done a lot around intergenerational activities, as well as some public education for their community. In Drumheller, their focus is really on reaching the most isolated, which of course we know during the pandemic became more and more urgent. They have developed a system where they have individuals that create individual connections with people, help bring those people to really small group activities, like 2 or 3 people, and then move them into larger community activities, creating that connection with them. It's been very successful for them. In the Three Hills in Kneehill County, they had a very small collaborative. When we started, there was 2 or 3 people. And so they've really invested their time in creating that active collaborative. And we just heard from one of their members that there's just a wave of activity now happening there. There's 16 volunteers that are actively running exercise, social interaction groups within that area. They actually serve 5 small communities within that Kneehill County. And then Stony Plain really focused on recruiting people with lived experience to their collaborative, as well as making sure that they were looking at sustainability right from the beginning. So the organizations that were part of the collaborative looked at how can we weave what we're doing right away into our ongoing activities with it. A big area for them was focusing on the emotional and psychological support for carers. And so what they have tried to do is in every activity they set up, they've got a walking group, they've got a gardening group, then there is space within there for people to share their feelings, to get that emotional support at that time. So kind of every space is a safe space for them. And in Innisfail, they actually created their own nonprofit society called Community Partners in Action, and that's helped them do fundraising as well as apply for grants. And they have really had a great growth within their virtual programs, started within the pandemic, but they still have 250 to 300 people signing in every week for their virtual programming. And then they've also tried new kind of structures where they've had pop-ups. So they run something for 4 weeks or 3 weeks. It helps with the volunteer recruitment as well as people making a commitment to those projects. So it's been quite amazing to see the magic that's happened in those communities. So a little bit about trying to understand the value of this work. We have just recently completed a social return on investment, and what it showed there is that it's just over $6 of value for the investment within this project to the return with it. What we really like about it is that we can see the value to the different partners that have been part of it, and you'll see there that for people living with dementia and carers combined, that is equal to the value for the publicly funded services there, and then some value to the teams also within the community there. It really emphasizes to us that that investment in well-being impacts the healthcare system. We did, as Sharon had said, done a return on investment for healthcare investment back in 2022, and it showed about $1.50 to $3.50 return on the healthcare investment, and that would grow over time with it. But it's pretty significant what we can get out of that, and it starts to describe the value of what we're doing. So where are we heading next with our work here? So we have received another 3-year grant from Health Canada. That's how our work has been funded. We'll be spreading this model to other new communities who are interested in supporting people living with dementia and carers. But we also believe that this model is applicable to other underserved populations, and so we will be scaling within communities, rural communities, to those populations. We're sustaining the communities that have already been involved, really to continue to learn about what supports their well-being to be able to do this work and continue to gather that evidence. We'll be doing lots of knowledge translation activities, but also a policy scan to look at, again, across the world, what are the policies that are in place that ensure that community work can happen. We've really noticed that part of our role is to kind of create that space, to not have kind of institutional and system pressures kind of squash it. And so it's looking at how we can continue to develop that. And of course, we will be moving forward with the evaluation and evidence gathering there. So just wanted to provide our information there. We have more cards if people would like more cards to take with them. Same QR code there for our website. So thank you so much.
Thank you. And our final speaker of the morning is Amrita Roy, also from Canada, talking about collaboration with Indigenous communities.
Okay, great. Thank you so much for having me. Let me just make sure that I got the technology working here. Okay, perfect. I know how to use the system. Excellent. So thank you again for having me. My name is Amrita, as mentioned, and today I'm going to be speaking about some work that we're doing in Ontario, Canada, specifically in the southeast region, in an area called the Frontenac, Lennox, and Addington, Ontario Health Team. So I'll offer kind of a bird's eye view of some methods and some very, very preliminary results of some work we're doing to explore what effective collaboration with Indigenous communities look like in the context of this kind of burgeoning integrated health system that is being developed here. And so I just want to situate myself a little bit in the midst of this. So I am a family doctor. I'm also a health researcher at Queen's University in Kingston, Ontario, Canada. I am not Indigenous. I am very much a settler in Canada, and I strive to be an ally. And one of the ways that I strive to be an ally is by working in collaboration with Indigenous communities in research. Previously in southern Alberta, actually, we were just connecting over our shared work in Alberta, but and then now in the last 4 years in southeastern Ontario, ever since I joined Queen's as faculty there. And so the research that I'm presenting today, it is very much in very close collaboration with the local Indigenous community in southeastern Ontario and very much driven by what the community is hoping to achieve in all of this. So in terms of a bit of background, so in Canada, the health system is largely a publicly funded system, and while governance is kind of split between the federal government and the provincial government, the healthcare delivery by and large is kind of overseen at the level of the province. And in Ontario, in the last couple of years, there's been a restructuring of the health system into these entities called Ontario Health Teams, which are these kind of regional entities that aim to provide coordinated, connected care through an integrated care model of the person-centered health home and health neighborhood model. And Ontario Health Teams are guided by the principles of the quintuple aim, which many of you may be familiar with. And one of the aims, of course, is pursuing health equity, which really highlights the importance of this work. So the Frontenac, Lennox, and Addington, Ontario Health Team specifically, it's in a region of southeastern Ontario. The kind of most significant large city there is Kingston, which is not large at all, but for the purposes of this region, Kingston is the big city. And it has brought together numerous clinical and community partners, including local Indigenous health groups. And so part of that formal partnership is that there are Indigenous representatives on all of the various working groups and support structures that are guiding the work of the Ontario Health Team. So in Canada, like in other parts of the world that have experienced the atrocities of colonization, Indigenous peoples face health inequities that are driven directly by the history and the present day impacts of colonization and colonialism, and also systemic racism. Correspondingly, improving accessibility, cultural appropriateness, and cultural safety of health systems is quite essential to address that reality. And to ensure that the unique needs of Indigenous peoples are met, there should be a collaborative, participatory approach to planning and executing Indigenous-specific evaluation activities with Indigenous-specific performance indicators. And that sort of is really the crux of what led to the conversations that led to this project coming about. And again, these were conversations that were very much guided by the Indigenous members of these working groups, and in particular the Indigenous Health Council, which was a key partner on this work and in the FLAOHT work in general. And so the research objectives that we came together around, firstly, is to co-design, implement, and evaluate a governance process for collaboration with Indigenous communities for Indigenous-focused evaluation of the activities of the FLAOHT. And from a research standpoint, to nest the above into a case study of the FLAOHT and the processes that are attempted to being followed, to examine those processes and see what we can learn and hopefully share with other organizations and other systems that may be able to draw on those lessons that we're learning on how to center Indigenous perspectives and priorities in systems evaluation and systems execution as well. So our hope at the level of the FLAOHT is that we can incorporate Indigenous-specific evaluation but also from an academic sort of, what can we learn more broadly from this? We hope that at the end of this we can offer a framework to operationalize collaboration between Indigenous partners and mainstream health systems in the co-design and co-execution of health system evaluation approaches that reflect Indigenous perspectives and priorities. So hopefully we can offer something that can be useful beyond the borders of the FLAOHT. We've heard a lot this morning about community-based participatory research, and this also falls in that same vein. And specifically, there's a set of principles known as the OCAP principles. So there's variations of this in various regions where Indigenous peoples sort of exist and where research is done. But in Canada, there's the First Nations principles of OCAP, which stands for Ownership, Control, Access, and Possession in Ethical Indigenous Health Research. So I think in an earlier presentation, the term nothing about us without us came up, very, very similar idea with the OCAP principles in regards to First Nations research. Correspondingly, there's a governance process for the research in which the research team, over and above kind of us, the academics from Queen's University, there's Indigenous members from the Indigenous Health Council and from the various working groups that are sitting at the FLAOHT. Those Indigenous members are working alongside the academics from Queen's University and also the leadership of the FLAOHT. And there's very specific, conversations that go on right from the conception of the research questions and the objectives to the design of the methods, the content of questionnaires and interview guides, group analysis when we get to that point, dissemination. So it's, every step of the way there is very deliberate collaboration to ensure that it is in fact meeting the needs and representing the voice of the Indigenous community. So very bird's eye view of the methods in the interest of time, of course. So as a precursor to the case study that's being done, we've actually had a couple of students of mine working on doing some rapid literature reviews with the hope that we can put together a toolkit of potential Indigenous focused evaluation approaches and relevant Indigenous specific performance indicators. And we're doing that in consultation with the research team, including the Indigenous members. So that's actually very close to being released. And once that gets released, we do hope to kind of release it publicly, so again, so that others can make use of it as well. But in terms of the case study itself, as per case study methods, we're hoping to draw on multiple sources of data to really understand kind of how things are playing out in the FLAOHT in regards to the collaboration. So we're working on document reviews. We've got some focus groups and interviews with Indigenous members that are in progress right now, and I've got some very early results to share in the next slide. And other data as appropriate as we iteratively sort of co-design in the context of this learning health system. So in terms of where we are now, so community-based research takes a long time. We've been doing this for now a couple of years, but again, it's the process matters as much as the outcome. So things are moving slowly, but we are moving ahead. And so at this point, our toolkit is almost ready to release. We hope that toolkit, once released, can really give some tangible resources to the various working groups as they look at their logic models for their evaluation and be able to really plop things down in that regard. But the one thing that's really exciting that's happening right now as we speak is the focus groups are underway with both current and former Indigenous members of the various working groups and support structures to really understand their experiences, or really as a first step to understand their experiences and draw some insight on the collaboration processes that are underway. And so these are very preliminary results. It's literally just from one focus group, so take everything that's written here with a grain of salt, that things may change as we hear more voices. But there's some interesting things that have come up that I thought that I'd share while I'm here today. So in terms of some successes, so we're doing separate focus groups for current Indigenous members, but also former Indigenous members, because there has been some attrition along the way. And so we recognize that that group that is choosing no longer to work with the FLAOHT might really offer a lot of insight onto challenges or areas for improvement. So this particular focus group is with Indigenous members who are still involved. So that group does comment on overall feeling heard and feeling welcomed, which is great. There's been appreciation expressed for being given a formal seat at the table. And there was acknowledgement of that, so that's great. But a number of challenges and a number of areas for improvement did come up even in this single focus group that was done. So some of the conversations in that focus group was around the challenge for these individuals of representing the quote-unquote Indigenous perspective when they are simply individuals who are Indigenous, and recognizing that the Indigenous communities are diverse and there's a lot of perspectives there. And if you have sort of 1 to 2 Indigenous members who are these isolated individuals in each of these, disparate working groups, what is the structure that will allow those voices to come together and offer a unified voice representing the entire Indigenous community? So that's a challenge and an area for improvement that was reflected upon. The other issue that's come up quite a bit is that in southeastern Ontario, the Indigenous community is not large necessarily, and the number of individuals from the Indigenous community in kind of health-related roles is quite small. And it's often these same people who are tasked and approached time and time and time again to do this type of consultation work. And so, there's sort of burnout from that role, but also an increasing sort of feeling that these small number of individuals are being asked to go farther and farther and farther beyond their scope of comfort. And there were some comments about, people starting to almost get hesitant thanks to even identify as Indigenous, because that opens up the floodgates of can you do this and can you do that and can you talk to this? So some burnout and some concern about scope and workload there. And so continuing along that line, so there needs to be more Indigenous employees in health service delivery. Again, there's just a small number there. And also, there needs to be a sharing of burden. So another thing that has come up in this focus group is that the burden of educating mainstream organizations and members of mainstream organizations on Indigenous issues often falls squarely on the backs of Indigenous peoples. And there was kind of reflection on the fact that in this day and age, there's actually quite a lot of resources available on Indigenous health. These are not new ideas, these are not new concepts. There's lots of documents, lots of modules, lots of training programs. And with a little bit of legwork, organizations can do a lot of this education kind of themselves without constantly relying on the communities to do that legwork. So sharing that burden and being kind of more supportive. And then the issue of tokenism did come up, which is a really important one, of course, with any type of community-based research, particularly with Indigenous peoples. So tokenism in regards to, first of all, the role of these Indigenous representatives on these groups, but also specifically around cultural competency training, which is kind of this off-cited, recommendation that always comes up around, improving health systems. Let's get everyone to do cultural competency training, all healthcare providers, all individuals in the system, which is great, so long as it goes beyond simply ticking a box. And so how do we make sure that these processes go beyond kind of a tokenistic ticking of box to something that will actually result in meaningful change and engagement? And to that end, the final sort of idea that I'll talk about is this idea of this perpetual consultation. These are not new ideas. We've been talking about Indigenous health for a very long time. There's lots of reports, lots of recommendations. In Canada, we had the Truth and Reconciliation Commission. It would have been, 2015, so almost 10 years ago. There was, the Royal Commission in the 90s. Like, these are not new ideas. And so when will there be action rather than just perpetual consultation? Because at the end of the day, that consultation, the burden of that really falls on the communities who are being constantly approached to talk and talk and talk. So when are we going to see action? And what do we need to actually move beyond consultation to action? So those are kind of some of the early findings, and we hope to hear some more as we continue to do these focus groups in the next few weeks. So just in the last sort of a minute or so that I have, as I mentioned, we're hoping there's a toolkit that's hopefully will be released fairly soon. Hopefully we'll be able to generate a framework that will be useful for organizations beyond the FLEOHT on what practical collaboration actually looks like. Hopefully we'll be able to get some Indigenous specific evaluation activities. As per the learning health system. So learning health system, the idea that we're sort of iteratively implementing a system, evaluating it, improving it, and so being able to have Indigenous specific evaluation will allow that hopefully to occur. But going back to something that's come up a few times, certainly throughout the conference and also this morning, the strengthening of relationships. At the end of the day, that's really where the crux of the matter is. And so hopefully this project will help strengthen those relationships and facilitate continued improvement of the system to address the inequities faced by Indigenous peoples. So I'll very quickly just acknowledge the many amazing people who are working on this research from the Indigenous Health Council, Queen's University, and the FLAOHT. I'll acknowledge Queen's University for funding this work, and I'll thank you all for listening. I think we're doing questions at the end, but I have just going to put my email address up there if anyone wants to offer questions or feedback afterwards. And as I said, if anyone is interested in this toolkit that we hope to release in the next few weeks, please shoot me an email and we can always send that, because we do want to make it very publicly available. So that's it from me. Thank you very much.
Thank you. We'd actually like to invite all our speakers up on stage, and by my calculation, we're going to need 2 more chairs. But I think we'll all fit. And we have a number of questions that have already appeared on the app. So maybe we can start with one of those, and then that'll give our live audience time to think of your questions. It's like musical chairs. Do we have enough? Yeah. Okay. All right. So our first question is for Charles. And the question is, did you follow up with your group, the communities impacted, to understand whether the work that you did actually changed their perception of vaccine, like whether it had an impact? Were you able to do some evaluation on that? Yeah, so the question was, were you able to follow up with your group to understand the impact of the work? And did it change perceptions on vaccinations, for example?
Yeah, thank you very much. That's a very relevant question. Yeah. The answer is yes, we did. And in fact, the findings helped us a lot to, for example, to create information sessions that we did online all through the platforms of the churches and the communities. So that the follow-up was certainly done. And the change of perception, that was rather difficult. For instance, what became very fundamental was around the then coming COVID vaccine. There was a strange story that came from France. The 2 doctors who talked about testing the COVID vaccine in Africa, and so that to see whether it worked in Europe. So this kind of remark was taken over by people interested in misinformation, and it was a very, very great barrier to the accepting COVID vaccine among African communities, the French-speaking ones, here in Belgium, in France, and the Netherlands. But the follow-up, yes, we did, and the sessions went on, in fact, both online as soon as the lockdown was released, also face-to-face. Thank you.
Thanks. So maybe what I'll do is I'll go back and forth between the ones online and just with the audience in person. Any questions yet from the audience here? There's a mic coming to you.
Hi, it's Michelle, who lives quite close to Rochdale from Salford, Professor of Social Policy and Inequalities at Salford. I just wanted to ask, how much is what you're doing tinkering around the edges, given the chronic underfunding of services and austerity?
Wow, ask us an easy one, why don't you? So that is an absolutely brilliant question. Are we tinkering around the edges? I think we're doing a little bit more than that. I think we are doing the best we can, understanding the resource challenges that we've got. And do we need more funding? absolutely. But do you know what? What we're trying to do is work together in a way that gives us the best opportunity to succeed. And what I think we have learned, and we all collectively understand, is that if we don't work together, we really can't deliver. We've absolutely got to maximise what we do. We've got to reduce duplication in the system, because there's loads of that, and we need to acknowledge and admit that. And then the best opportunity we've got is working together. So I don't think we're just tinkering. I think we're giving it our best shot to do as well as we can.
Great. The next question is open to any of the speakers. What are good practices to engage or bring together professionals for building and integrating the care? Anybody want to start?
I always have to take that one because I'm a physician as well, because it can be very difficult, I'm sure, if you guys have tried to engage physicians in the work or other healthcare professionals. And I think actually one of the best ways is actually to find an in with somebody who's interested, who's going to become your ambassador and help you actually spread that word, because I feel it's like a little bit sad, but I feel healthcare professionals trust other healthcare professionals a bit more. But it is difficult to engage because they're always overworked, you know, and they have too many asks on their time. But I think that if you find somebody who's passionate in that area to help you advocate and spread that message, you're going to recruit other people who will feel the same way.
Anyone else want to respond on that one?
Yeah, I would like to agree on the same note, because I'm a physician as well. I think the key element which I mentioned in my presentation as well, that communication is the key. If you trust your partners, if you trust your colleagues, and that actually is not only in between the clinical team, we want to obviously expand it to the managers as well, because usually there is always a difference that manager says something, clinician, obviously there is a rift. I have seen there is always a kind of a primary care work, a secondary care work. So when we talk about integration, we have to talk common language, and trust and communication and reliability. These are the key elements which can only be achieved if you are working within a team on the same wavelength. So definitely it needs to expand beyond the clinical team as well. We're trying to, as I mentioned, there's none of the system in the world is perfect. That's why we are here. So we want to learn that how we can improve and how we can make it better. And communication, that's actually is my mantra of working, and I think it's working so far. The team is here. That's why not single presentation, 3 presentations.
Wonderful, thanks. Other questions from our live audience? Okay, a question for Sandra and team for the work that you did in Rochdale. What are the funding arrangements for third sector organizations involved in your model? For example, are they commissioned? Is there external funding? How does that work?
Okay, we're getting the really tricky questions here, but it's fine. So our voluntary sector is always a challenging area, because we know that absolutely there needs to be more funding shifting into our voluntary sector than currently is. What I would say is that we're really focused on doing that and really keen to do that, and we work really closely with our voluntary sector. So we have in the past, we have only recently just actually received the outcome of a piece of work where we invested a significant amount of money in our voluntary sector, who supported some of our engagement activity across our organisations and with our population, to make sure that when we developed our business plan in terms of what we're going to deliver, we were delivering the right things. It is a key aim for us to shift funding into voluntary sector. We've got our voluntary sector Action Together representative in the audience, and with us here, along with other colleagues in where am I? In Antwerp, sorry, I forgot the name. So we are working really, really closely. It's not perfect, but we are doing our best to shift that funding, because we know that that's where we'll really get to see those improved outcomes.
Great. And I'll just keep scanning the audience. Put your hand up if you have a question. Yeah. All right. We're going to get you a mic.
You're talking about link workers. We had Marie and Essam talk for us in Canada about how the link workers work. Now, you've placed them in primary care. In Alberta, we're looking at placing them in senior centres. What are the benefits of having them in primary care? Or would you think they'd be better in senior centres?
Yeah, it's a part of the wider system. They're not actually part of the primary care. Yes, it's mainly because we talk about the funding flow, so that funding flow is through the primary care network, but that SPLWs are available to the entire system. So even the community matron, if there is any problem with the housing team, anyone who's visiting, they can still link, for example, if the housing team person visit and they feel there's something which is more pertinent to the GP, but they're finding difficult access to that, or the nurse could do that. So the link worker is the connection, obviously, who can signpost. And what we have done, that we have developed a mechanism within the SPLW structure as well, which class any patient as red, amber, and green. So any of the system person, if they make a referral to SPLW, if it says a vulnerable patient, elderly patient, problem with the learning disability, then they'll be classed as red. So they keep them on their caseload as well. At the same time, signpost and link to the right, relevant, person within the neighborhood structure. Amber is less. Green is you signpost, connect them, and then you can pass on. So in this way, there is always a mechanism where we can keep the caseload, which is like vulnerable patients, and that in turn helps the wider system, less admission to hospital, less emergencies.
The question was, is there a shared record?
Yeah, we are working at the GM level as well. The information is shared in between the other agencies as well. Again, this is a process in place. The electronic system which we use, obviously, that keeps all the data, but that's being visible to the district nurses and other agencies as well. Because of the new GDPR rules and regulations that actually going through the process, but I think it is on the way. Hopefully in the next 1 year we'll be able, unless if you want to add anything. Yeah.
Right. Oh, I'm going to move on to other questions.
Yeah. I'll see you after that.
Yes, please connect after. Question for Amrita. Can you elaborate on how you've collaborated with Indigenous people in developing the toolkit?
Thanks very much. Sure. So with the toolkit, we had a couple of students working and are still working. But we approached each of the working groups and got a sense of kind of what evaluation they were hoping to do and what their needs were. And again, each of those working groups had Indigenous members on them. And then in the context of this case study, we also approached the Indigenous members on the team for the case study as well. And so, we kind of approached on what kind of indicators or what kind of questions are they looking for evaluation. We then, once the students kind of came up with their search strategies and keywords and so forth, we again went back and got kind of an additional layer of feedback. We got initial layer feedback again when we got the preliminary results, and then a preliminary write-up as well. And so we've sort of, at every step, we've been kind of going back and saying, is this meeting your needs? How would you tweak this? What would be useful for the group? So.
Great. Other questions from the audience at the back there?
Okay, so I'm curious across the group. We spend a lot of time talking about consultations, and I'm an academic. We spend a lot of time with papers and presentations. Just looking for some practical tips, like how do you get this into the hands of the communities? Like I love these posters, these little QR codes. That's a great idea. I like it as an academic, but what works getting the information to the people that we're consulting from?
Thank you for that question.
I want an actual practical idea that I can put in my pocket and take home.
Yeah. It's a lot of the work, especially at the beginning of the grant. And, it's around developing relationships. So prior to the last 3 years, there was a lot of work done connecting with communities within Alberta to see who was interested, and then following up with them to hear what was work already going on there, and then building upon that. I think it's really, really key that we're listening first, and we're hearing what is important to them, and then working from there and building on the strengths that they have already. Because I think sometimes we come in with, here's what we want you to do. And then they're out the back door pretty quickly with that. Yeah, so I think that would be my key one, is see who's interested, start with them, but listen to what they actually want to build from there with it.
Go ahead. There's one. Oh, I'm sorry, do you want
Well,
to?
we already started working towards our learning objective. So I believe, or we believe, this is one of the concepts we discussed about, new methods of communication. As I mentioned, communication is the key thing. And that actually should be reflected in the communities. New world, digital world, we thought about having the podcast, videocast as well, which is like public-facing, staff-facing as well. Most of us, we are so busy in our life, we don't have much time looking into the emails. By the end of the day, you finish the day, you say, okay, next day, and then it just, buries down in the email. Same thing happens with the public as well. Attention span is low. There's limited information because there's so much on the system for there to review, so it should be targeted. It should be the new methods which obviously the population want to hear, and it should be based upon how patients want to see things, how they want to listen, and then we have to change our model and structure towards the well-being and holistic care. So obviously that would, give a better understanding to the system leaders, like they can pick things up accordingly and make all these strategies at the high level accordingly. So I think the communication method should be more modern, rather the older style only.
Great. I think we probably have time for one more question. No, you need the microphone for the people online.
Hi, my name is Vicky and I work in Inverclyde in the west of Scotland. So there's been a lot of talk about relationships and working in teams. We know that people live in communities, not in services. So how do you ensure that the voluntary sector are equal and respected partners, trusted as well?
That's a great question.
We work really hard to do that, and there's no easy answer. So I've said that our voluntary sector are here with us in Antwerp. Our voluntary sector are represented in all of our groups, in all of our at all levels, both operationally through to our local care organisation board. They're part of our decision making. They're part of our senior management team that support that decision making. So we work really, really hard at every level to make sure that they are really part of our system and not something that we add on at the end, which is so it's not tokenism. Absolutely, we can do more. There is no question of that. But we work really hard at it, and I think that's the answer, because we want, and we all have a shared commitment to work with our voluntary sector, and because we have that relationship, we work as hard as we can to make that happen.
You've made my third sector heart very, very happy.
I just wanted to add to that, in the communities that we work with, often it is the third sector who is leading the work. We do a lot of work with family and community support services. And so it's really an equal partnership. It's that collaborative team, multi-sector team, that's deciding the priorities. And so it's not, the priorities aren't set by the healthcare system in doing the work forward. So, and it's actually that sector who gets this work and knows how to do it automatically. And so we're learning in the health system from them about how to do it.
All right, I think we'll bring that to a close. Thank you so much for your participation. I'll turn it over to Mandy.
Can I just say, one of the things as you go away from today, there's so many key points that everybody has learned. Please maximise your connections, take on your shared messages that you have learned, and think within the next working week who you're going to connect with and share what you've heard this morning. Thank you very much for your time, and let's continue to engage.